Welcome everyone. My name is Philippe Généreux from London Valves 2025 and have the great pleasure to be with my good friend, Canadian Philippe Pibarot from Quebec. And today we're going to talk about a very exciting topic, the findings of Partner 3 in low-risk patient, TAVR versus surgery. And we just heard the 7 years result at TCT. Philippe, first of all, can you summarize for the viewer the main finding in the trial of P3 trial?
Yes, so the P3 trial was, as a reminder, TAVR versus SAVR in symptomatic severe AS, patient being at low risk, and we just reported the 7-year results, so showing that the primary endpoint, which is the composite of mortality, stroke, and rehospitalisation, the rate were similar at 7 years. If we remember, at 1 year, we reported that TAVR was superior versus SAVR regarding the primary clinical endpoint, but then this difference between the two arms attenuated progressively. Already at 5 years was observed, and then at 7 years the rates are very similar. And with regard to all-cause mortality, which is of course something that people were looking at carefully, there was actually all-cause mortality. The rates were low, as expected in this low-risk population, and very similar between arms.
So somehow very reassuring data for clinician.
Indeed.
Two good options. The main question why the 7 years data of balloon expandable versus surgery was so important is to tackle a question, unanswered question about valve durability. And then does the promises of TAVR is fulfilled compared to surgery up to 7 years? What did we learn from Partner 3 7 years result in terms of durability?
Yes, so indeed, in this low-risk population, patients are younger at the time of implantation, they have longer life expectancy, so the long-term valve durability becomes a key issue, And as you know, there was concern that TAVR may be not as durable in the long term versus SAVR, and so we're all waiting these results of the first randomized trial in low-risk patients, and actually the results were very reassuring because we found that the valve durability was excellent in both arms and similar. The rates of all-cause bioprosthetic valve failure, which is probably the most robust marker of valve durability, was in the 6%. In both groups, and it was actually numerically higher in SAVR versus TAVR, but of course not statistically significant. So far so good. And 7 years is it's the beginning of long term. We had midterm data that were reassuring, but this is now long term. There has been other trials, but like the Notion trial, the Partner 2 trial, but these were in patients with intermediate risk, older, and so there was a major survivorship bias. So you cannot derive any meaningful conclusion from this trial. But Partner 3 now say it's very reassuring in terms of valve durability.
And it's very important for patients because now we can sit with them and say up to 7 years, only approximately 5% need a re-intervention, which I think is excellent news for patients. So Philippe, you were the core lab of all those trials. You had the luxury to see all the echocardiogram at baseline and every year up to 7 years. So can you tell us what remained to be improved in those valves for TAVR valve, for example, or for surgical valve? Is there one thing to improve in both technique that we learned from Partner?
Yes, I think so. I think, although the results are excellent, as they are, but still I think we can do even better. And let's start with SAVR first. I noticed that most of the cases of early structural valve deterioration that occurred with SAVR were in patients with very severe prosthesis patient mismatch, in small annulus, often women. And so I think one thing that could be done on the SAVR front is maybe perform more wound enlargement when it's feasible and in good hands with experienced surgeons, and try to use the largest possible valve with the best hemodynamic performance to avoid mismatch and therefore eventually reduce the rate of structural valve degeneration. On the TAVR front, I think most of the failure occurred in patients that were suboptimally deployed, often under deployed. So you have, or they are not the deployment is not perfectly circular and optimal, and this creates mechanical stress on all leaflets or one leaflet, and eventually this will predispose to thrombosis and then to structural valve degeneration. So one thing you could do is really to optimize the positioning, and optimal deployment of the valve. And I think, as we are moving toward lower risk population with maybe less calcification, I think this will also help to improve, because one of the limiting factors, as you know, for optimal valve deployment is when you have a heavily calcified valve. And so I think this also will help to get even better durability in TAVR.
I think those technical aspects to improve and ensure we have optimal durability is important both for surgery and TAVR. So I want to wrap up by asking you, what is the message for clinicians? How is it going to change our practice now that we have two good options with TAVR and SAVR for low risk patients? Let's say a patient of 70 years old come to see you tomorrow. What are you going to say to clinicians? What is the key message of PARTNER 3 up to 7 years?
Well, I think it will simplify our life, because now you have two excellent options, both in terms of clinical outcomes, valve durability, and I think you need to sit with our team, look at the CT, and then decide which is the best procedure for a given patient, and of course share decision making, because even if maybe SAVR is the best option given the anatomy, maybe this is not what the patient prefers. And so we have to listen to the patient, but at least you can say to the patient, well, so far the two options will provide the same durabilities, and I think in terms of lifetime management, it makes sense to start with a TAVR, especially in a 70-year-old patient. So yeah, I think now the field is more open than before with this new result, I think.
I think the result of PARTNER 3 up to 7 years showed that the heart team, with a great discussion around the CAT scan to assess the anatomy, the suitability for TAVR surgery, and the heart team discussion with the surgeon, the clinician in the center, this is the patient, is even more important. So I want to thank you, Philippe, for your time. I would say that the key message of PARTNER 3, 7 years for me is, first of all, both TAVR and SAVR up to 7 years have very good clinical outcome in terms of death, stroke, and heart failure hospitalization. Second, very reassuring, the durability of both strategy, TAVR and SAVR, extremely good up to 7 years, around 5% reintervention, which is very pleasing. And I think I will finish by saying that there's never been a better time to be alive with AS, I believe, because now we have great option. And the heart team, it will be very important. So from London Valve 2025, thank you so much, and hope to see you soon.